Okay. Now this next speaker wears about 3 or 4 hats, or has worn about 3 or 4 hats. Many of you know her from the time working with Riley Hospital for Children Emergency Department, and most recently as the Deputy State Health Commissioner and Director for Health Outcomes at Indiana State Department of Health. She is now serving as Secretary of the Family and Social Services Administration. Ladies and gentlemen, put your hands together for Dr. Jennifer Many Hats Walthall.
Thank you. Good morning, everybody. I was asked to be your closer today, which is my favorite job to do, because everybody generally has already said everything that you needed to know. But I thought that you might wonder, what in the world the Secretary of FSSA would have to do with infant mortality. Well, number one, it turns out that we're all public health, and it's really good to be back among my public health people today. So thank you so much for the invitation. It also turns out that FSSA does some pretty cool stuff. When I called my mom back in January to tell her about this new job, she did what all good moms do, which is just gush and, oh, I'm so excited for you. This is really wonderful. And then there was a brief pause, and she said, what is that? Which is appropriate. So FSSA is a large agency for the state of Indiana, and one of the things that we house within the agency is Medicaid programming. And you may know this number. Indiana, we have about 80,000 new babies every year, which is a pretty cool thing. Indiana Medicaid covered last year 48,000 of those babies, which means that we have a responsibility to taking care of infants and infant mortality and moms and families and communities, and that my new job may actually be more directly tied to the success of infant mortality and the opiate epidemic than any of my previous jobs. So what I want to tell you a little bit about today is, as we close the morning session, is that this is more than just a single labor of love. It requires multiple laborers in the field, and we need everyone if we're going to make this work. I'd like to describe to you a little bit about what I call, and what many call, the Swiss cheese effect, which is why we're here today. The Swiss cheese effect is when you look at an outcome and then you look back on why that outcome occurred. It usually turns out that it happened because a bunch of things that should have never happened in sequence lined up perfectly to let that bad outcome fall through all of those holes. And we've heard this described in multiple ways today, that outcomes are designed by the systems that we create, right? We create those things, and then the unintended consequences turn out to be the things that actually the system was designed to build. So the Swiss cheese effect that we're seeing now in infant mortality, and even more importantly, the bigger piece of the iceberg that's under the water, infant morbidity, right? So not the deaths of infants, but the effects of those infants who don't die on their own lives, their families' lives, and our communities, the consequences are really untold, especially when we start to delve into this explosion of neonatal abstinence syndrome and its effects on infant morbidity. So let me tell you just a quick Swiss cheese effect story. So I still work 1 shift a week. I'm privileged to work 1 shift a week in the Riley Hospital emergency department and see kiddos. And just a month or so ago, I saw a family that really brought this home, yet again, the connection of the macro of policy to the micro of individual families. And this Swiss cheese story goes a little bit like this. I was working in the ER, and up on the board came up a 12-day-old infant with a fever. Now, you know very well that having a fever when you're under 1 month old it blows up the whole system, because we know that those infants don't have any sort of immune system to combat the infection that might have caused that fever. And so we do code fever in the Riley ER, and it's the same every time. Everybody gets the same thing. It's just this standardized, beautiful thing to watch. All the nurses know what to do, all the doctors know what to do, all the techs know what to do, and we get the job done. And so over time, code fever gets a little bit kind of boring, because we just do the same thing and you don't really have to think about it because it's just kind of pre-programmed. Well, this particular code fever was really interesting because when I walked in the room to get my part of the job started, the baby, who's super cute, was being held by an older gentleman who was by himself. And so I kind of asked him, hey, how are you doing? Is mom coming, right? And he said, no, I'm grandpa, and this little baby is in my care and has been in my care for the last few weeks. So I kind of did my part of the medical stuff, but I was chatting with grandpa as I was doing the spinal tap and all the rest and kind of getting the story, because he was a really interesting gentleman, very kind face and easy to talk to. And he said that what had happened is that when mom was early in her pregnancy, she was diagnosed with a kidney infection and had a lot of pain and was prescribed a fairly high-dose opiate for this process, and then had just never stopped. And she realized kind of midway through the second trimester that she was in trouble, that she was having some big-time problems. And she went back to her OB doc and said, I've got to get off of this stuff. Something is really bad, and I feel bad when I don't take it, and I'm not really sure what's going on, but this is pretty scary stuff. And she was told somewhere in the process that that if she was already feeling withdrawal effects if she didn't take the medicine, that she shouldn't detox during pregnancy, that it was dangerous and that the baby would die. And so because she was nervous and also had, from the description, a real substance use disorder issue, she was placed on a wait list for treatment. And unfortunately, her medication ran out. And right before the baby delivered, because she couldn't get any medicine legally and was still on a wait list for treatment, she bought a prescription drug on the street. And she was arrested for that, was caught and arrested. And so after delivery, the infant was removed from her care because of her arrest and because of her positive drug screen, and went to live with her dad. So this is a story of all of our systems failing. And we can do better. We can do better. And so the goal of all of us being here today as laborers, all of us, plural, laborers of love, is that infant mortality and the opiate epidemic the responsibility for this doesn't lie even in this, 7-bulleted story. We have so many partners that can come together if we think about how we do this just a little bit differently. We can point the finger at doctors. I'm one of those too, so I'll point the finger at me. We can talk about a wait list for treatment. We can talk about communication between healthcare teams. We can talk about communities coming together, pharmacies coming together. We can talk about how we partner with the Department of Child Services to make sure that we're all talking to each other about how best to support families. So many solutions are embedded in this Swiss cheese story, and I'd like to spend just a couple of minutes talking with you through some of those solutions and how a partnership between FSSA, which is truly a healthcare kind of finance agency and a social service agency, partners and thinks about how we do things with a public health lens. How all of this together, when we think about this big, hairy problem of infant mortality in the state of Indiana, that if we pick it apart and just fill the holes so that babies are not falling through and moms are not falling through, then maybe we might actually get somewhere. And so I want to talk a little bit about some partnerships and then highlight a few things that you've heard maybe a snippet about today that I'm really excited about what these next couple of years are really going to look like for us and how we can partner together. The first, of course, is the powerful story you just heard about IPQUIC. Wow, what a great example of how just a few people with a really good idea and a best practice could say, we can do a best practice better than anybody if we bring people to the table and let all of their voices be heard in collaboration. So if you're not part of IPQUIC, I would really offer that you should be. And in fact, FSSA now has folks who are part of IPQUIC so that we can learn how to do our programs better and deliver our social services better because of the way that IPQUIC is framing the problems. We also are partnering to fund and distribute naloxone throughout the state. Everybody needs to have naloxone. And the reason that we're doing that at FSSA is because it's really hard to put somebody on the path to recovery from their grave. And that when we think about when people should get naloxone, I don't particularly care if they get it on their first, if they get into recovery on after their first overdose or if it's on their 99th. I just want to make sure that we are making that opportunity available for everyone. I never thought that we would have to have emergency caches of naloxone in our state, but we do. We do because the opiates that people are overdosing on are more and more and more potent and powerful, and we're using multiple doses. But until we get past this emergency, we need to make sure that the antidote is available for everybody. And for those of you who don't know how to deliver naloxone, there's a class this afternoon on how to do it. I actually do a live demo every time I talk about naloxone because it turns out that if you haven't overdosed on an opiate, which I haven't, and you give yourself naloxone, it's just like water and you're fine. So it's pretty easy and should be something that everyone has available. I actually have a kit in my glove compartment in my car. I haven't had the opportunity to use it yet in the field, but I know that the Attorney General of Kentucky actually saved someone at the beginning of October. He was driving down the street, saw someone slumped over the front seat of their car, pulled over, stopped, delivered naloxone, and saved their life. Pretty incredible stuff, and Indiana has wonderful policies to support this. We also are supporting local health departments becoming Medicaid providers. Who would have thought that that would be the case? But we've got almost half of local health departments enrolled as Medicaid providers so that they can have a sustainable source of funding for these public health outreach initiatives to support moms and dads and babies and families at the local health department level. We also are supportive of Jim McClellan's incredible work in the Next Level Recovery Project to make sure that all state agencies are communicating not just with each other, but with the public, so that stakeholders and mayors and police chiefs and ambulance service chiefs know exactly what's going on and what best practices are around recovery at the community level. We also support the nurse-family partnership. We think that early, frequent home visiting programs that have sustained communication and collaboration with families are the model for reducing infant mortality for the future. And the Nurse-Family Partnership is one of many examples, but one that we've really been proud to partner with both at ISDH and FSSA. We also support Baby and Me tobacco-free. In fact, FSSA is part of the program called the State Employee Community Campaign. And FSSA employees this year have donated all of their contributions to the Healthy Hoosier Foundation, which supports new development of the Baby and Me tobacco-free program, which is pretty cool. So a couple of things that are going on within FSSA. You've probably heard about this little tool that we've got called the Healthy Indiana Plan. So the Healthy Indiana Plan has been part of the national spotlight over the last couple of years because it's the only program like it that expanded Medicaid access in the way that it did. And so we are at the end of the road of the Healthy Indiana Plan 2.0, round 1. It ends February 1st of 2018. And the renewal process is ongoing to get round 2 of HIP renewed so that we can do it for 3 more years. Now the part of the Healthy Indiana Plan that is the most timely for us today is that we've built into it a massive substance use disorder package. In fact, the substance use disorder treatment that you will be able to get under not only the Healthy Indiana Plan, but all of Medicaid is, I think, at the forefront of how this treatment should be designed for the entire country. And so again, the spotlight of national health care is on us as we propose these programs. We're expanding inpatient detox services. We're expanding residential treatment services, addiction recovery support services that think about patients where they are, not where we are. So not every patient needs to go into a detox bed or into a residential treatment program. Sometimes they need a peer recovery coach to help them through their medication-assisted treatment. Sometimes they need to be able to meet at a Starbucks and talk to someone who's been through what they've been through and help them out. Sometimes they need to be able to go to a recovery program in the basement of a church. Sometimes they need to just be able to move for a little while and have some support for a new house. Can you imagine trying to teach landlords how to bill Medicaid for rent? Pretty cool, but we have a work group that's doing just that. Again, going to people where they need to be met with treatment and recovery, not where we've decided is appropriate for us as a healthcare system. We also are working on relapse prevention services being covered under our SUD package, and a waiver of the current Institutions for Mental Disease program that's been in place for decades to allow some of our larger facilities to keep people that need maybe a little bit longer treatment than just a 3 or a 7-day revolving door to really get the services that they need where they need it. We also have in this package expanded pregnancy coverage. Again, 48,000 births covered under Indiana Medicaid last year. We know that just because you just had your baby doesn't mean that you don't need health coverage anymore. And so expanding that access out beyond the time of delivery to include these wraparound services specifically for moms that need SUD treatment, but really for everybody. This is not just an SUD problem. This is a public health and healthcare access problem. Now here's the fun part. About a year ago, the federal government decided that we needed a little bit more help. And so in April, Indiana was awarded $10.9 million for year 1 of the 21st Century Cures program. Now, because we'd already been doing some incredible work in the past, we actually were able to use all of our 21st Century Cures dollars for new programs. We didn't have to do it to kind of buffer old programs. We were doing a great job already. So every single thing that we did in year 1 is a novel pilot program that we think is going to revolutionize the way that we not only treat the opiate epidemic, but substance use writ large. The first is expansion of treatment capacity. We are going to be adding over 400 new beds to our treatment capacity for the state of Indiana. And not only are we doing that, but because we were able to, because of this process, map out where our treatment is and where we need it the most, we were able to kind of target where our gaps are and fill in treatment capacity based on data. That's a novel concept, I know. But then because of that, we also realized that we needed a universal wait list. You know, we talk about this all the time. I have a patient in the emergency department and I say, okay, you need some treatment right now. And they say, yes, I'm ready. And then I say, well, you're going to need to come back in a week because I don't have anything. We can't do that anymore. But as we did this global assessment, it turns out that Indiana actually does have reasonable treatment capacity. We're just not using it very well because we don't have a centralized source of truth for what I call the wait list with a capital W. And so we are partnering at FSSA with Indiana 211 and the Open Beds Company to build a central repository for treatment capacity. So it's basically an eHarmony for treatment for mental health. So you got a patient right in front of you at 2 o'clock in the morning in the ER that says, I'm ready, and I need some treatment. And you say, well, the local place is full, but I'm going to get on Open Beds and call 211, and they've got every provider in the state that updates their availability every 24 hours, and we can connect you right then at the teachable moment to what you need. This, again, is revolutionary, and we're the first state to do it. It goes live in first quarter of 2018. We also were able to start through the 21st Century Cures grant and ECHO program for medication-assisted treatment. It turns out that even though I thought in my garden I would be able to grow addiction psychiatrists, I can't. But what I do have is a network of really committed primary care doctors and OBGYNs and surgeons and pediatricians throughout the state who want to be part of a solution and didn't have the capacity to do it before. The ECHO model is a train-the-trainer model, so that individuals who live in the middle of nowhere, truly in the middle of nowhere in Indiana, who say, we've got a problem here and I want to be part of the solution, I'm going to engage in this training program and I'm going to do MAT in my office. That's really important, number one, because it really empowers our existing capacity to do incredible things, and it also, at the same time, and maybe even more importantly, reduces stigma. Can you imagine being able to go to your primary care doctor who you already know and love and trust and get your hypertension treatment and your MAT in the same place? Pretty amazing. Nobody knows. You can go in and just have a normal, destigmatized, disease and wellness-based interaction with your primary care doc. That's pretty cool stuff. We also are mobilizing 2 treatment teams that will be able to, based on our data dashboard, look for hotspots throughout the state where we're seeing increased hepatitis C cases, increased ED overdose visits, or coroner's reports of deaths, and go to those spots and do on-site immediate responses for treatment building, community resilience building and capacity evaluation. So those 2 mobile addiction treatment teams are going live very quickly because of this program. We also were funded more naloxone for first responders, for our Department of Natural Resources folks, and for local health departments, and are enhancing neonatal abstinence syndrome pilots throughout the state, again, with the previously stated goal of keeping moms and dads and families and babies together. And then finally, one of my favorite, because it was born locally here just right across the street at Eskenazi Hospital, is the ED Peer Recovery Program. At Eskenazi, there's a program called Project Point. For every patient who comes into the Eskenazi Emergency Department who has had a naloxone deployed in the field, they are connected with a peer recovery coach right then and there in their moment of teachability that says, we can do this together. And what that does is it bridges the gap between when they leave the emergency department and when they start their treatment. And we're going to be able to fund 10 of these programs through the 21st Century Cures grants in rural spots across the state. Really extraordinary stuff. And guess what? Year 2 is coming in just a couple of months, and we get to do this all over again. So really exciting things going on for infant mortality, for moms and kids and babies, and for the opiate use epidemic for Indiana. I'd like to brag for just a little bit on our Medicaid team. The Medicaid team is a really smart group of people. And every once in a while, when you ask them to kind of get up out from behind their computers and the forms that they fill out and making sure that nothing's going to break and everybody's going to get their eligibility, and you ask them to do something a little bit more exciting and a little bit more connected to the people that they serve, they go kind of crazy. And so what we talked about, and we started this with this idea just a little bit over a year ago when I was still at ISDH, was the idea of building out a program that would support community health workers. Again, the idea that the medical model might not be enough, that maybe we need to get outside of our boxes a little bit and go help people be healthy where they are. And the community health worker has never really been a formal part of a paid provider because we didn't really know how to define them or how that might work. And so this team was tasked with kind of taking a little idea of what if we thought about reimbursing community health workers as part of a medical team, and they went completely crazy. And so they all signed up to be trained as community health workers so that they would understand what they do. And they got so excited about it that they built this glorious policy that is going to extend the reach of our healthcare system for the state of Indiana and expand that medical care to the community in a very patient-centered way. So what we will have is the ability for one of the hundreds of definitions of what a community health worker is. So whether that's a community-based lactation consultant or a diabetes dietitian or a peer recovery coach or you name it, that community health worker under a rendering provider can be reimbursed under Medicaid for the services that they provide to really make our system robust and work for families and work for connectivity and really start to move the needle in our health outcomes. You've heard me say this joke, and the joke gets older and older every day, is that we have to stop aspiring to be the top of the bottom quartile in health outcomes in Indiana. And I think that this is one of the ways that we can be transformative in actually accomplishing that. The scheduled go live is mid-2018, and I want as many of you as possible who are engaged in community health worker work already in an unreimbursed way to send us your feedback. We want to make this program really robust, and we want it to be supportive of infant mortality home visiting efforts. We want it to be part of opiate recovery processes and all substance use disorder processes as well. There are many parts of FSSA that labor in the labor of love with you that might not be ones that you think about initially when you talk about substance use disorder and infant mortality. The first and my favorite pet program, because it's small but mighty within FSSA, is First Steps. And I know there's a lot of folks who love First Steps in the audience just as much as I do, but this is the early intervention and prevention part of how we take care of kids for the state. And these folks truly do God's work in homes, in communities with families, and get kids to the point where they can function at their maximum talent level. And the First Steps folks are doing this in the setting of increases in referrals of 15% or more a year largely due to babies born with exposure to substances. And because of that, we have to support them even more than we have in the past, because I think the key to making sure that these kids do well is that they've got to have a first steps provider in their home, and the first steps provider in their home that knows how to interact with families that are dealing with substance use disorder. Another shout out to On My Way Pre-K, which has expanded by 15 counties, and the applications are open, so if you're in those counties, you should sign up. Folks ask me, what if you were going to say one thing that's the key to combating the opiate epidemic? Of course, the first answer is prevention, right? We have to get folks who need treatment right now in the treatment that they need, but then we need to prevent the next generation from having this issue at all. And the way to do that is early, quality childhood education. And On My Way Pre-K is a great example of how to do that. We also have a brand new service that's starting in April of this year, of 2018, and that is a coordinated service to do non-emergency Medicaid transportation. You've heard this story before. I had an appointment at 2 o'clock. I took 3 buses in the day off of work to get there, and I got there at 2:45, and there's a 2 o'clock cancellation policy, and so the next appointment available is in 9 months. We can't do that anymore. So our new Medicaid Transportation program is going to be the equivalent of Uber for Medicaid. Patient-centered and really exciting work. We're also big time in supporting MAT policy to make it easy and accessible for folks who want to do medication-assisted treatment correctly, and difficult for those who want to profit off of it and capitalize on opportunism within the opiate epidemic. Also within FSSA, we do child care certification and training for child care throughout the state, and we are really looking hard at those policies to make sure that we're supporting everything that public health wants us to be doing in the child care setting. I'll tell you, just in my first 8 weeks in this job, there were 3 child care home deaths due to unsafe sleep conditions, and we can't do that anymore. If we expect safe sleep to be occurring in homes, it has to occur everywhere, and that's certainly when we're under the watchful eye of a certified child care. And so enhancing safe sleep conditions across every sleep, every time, the ABCs, is something that we're committed to doing with you, and I know that you're committed to doing with us. I was supposed to close this with some thoughts about what we've heard today and kind of rally everyone to a call to action, and I've written a couple of things down. The first that I think we've heard from everyone today is that we have to be together. None of us can do this by ourselves. Just this last year, I took my 2 boys, who are 12 and 17, to the U2 concert in Chicago. And it was really amazing. So watching them see U2 for the first time as a long-time U2 groupie was pretty cool. In fact, when Bono walked out, the sun was setting over Soldier Field and looking out over the lake. And my 12-year-old is standing next to me, and Bono walks out onto the stage and rips out the opening chords to Sunday, Bloody Sunday. And Jack looks over at me and goes, "No way! Yeah!" Like that, you can't do that again. But you can't really make those moments up. But I remember thinking when they started playing One, and there's like 100,000 people in the stadium, and they're all singing at the top of their lungs. I thought, if we could capture this sort of energy around a song, what could we do if we actually captured that sort of energy around something that really impacted people? And so I think what we've heard today is actually some really great ideas on how we can do that, but we have to do them together, across silos, across what we think we should do, what our lanes should be, across public health, across public safety, across hospitals, across providers, across communities, across not-for-profits, across faith-based organizations. All of those things coming together, and no way, yeah, is possible. The second is that we have to recognize ACEs, or adverse childhood events. When I first started learning about these as a resident, I thought of it as, what would happen if we could all have the little floaty thing, like in the cartoons, with our number right above our heads? And how might we treat each other differently if you walked up to somebody at the grocery store and they had a 4, right here, would you change the way that you looked at them, or your body language? Or would you be a little bit more patient in the checkout line behind, or at the dry cleaner, or at the gas station? I mean, what if you ran across somebody who had a 7? Would you just run up to them and give them a hug? Like, maybe we would do that if we could just walk around with our aces right here. And so my suggestion was just to be, why don't we just assume that everybody's got a number? And let's live that way, and just assume that perhaps maybe even though we might not have a number, that the people that we're interacting with do, and maybe we could treat each other just a little bit differently, especially right now, but for the future as well. Number 3 is that we need to start embracing prevention. It's a whole lot easier to respond to the fire that's burning in front of us, and a whole lot harder to kind of get upstream and prevent things before they happen. But I'll tell you, it's a better business model than fires, for sure. And so let's kind of get together and think about that. I talked to a mayor of a small town just a few weeks ago who was saying, I really feel bad about not being part of the solution for the opiate epidemic. I said, well, what do you mean? He said, well, I really feel like I've learned a ton at this conference we were at today, and I really feel like I kind of missed the boat because I ran on a platform of building more parks and community events and things like that. I said, well, that's your opiate strategy, right? That's the prevention model for the opiate epidemic, is to bring communities together. So all you got to do is brand that baby. Build a park, have a party, bring your communities together, and that is your prevention strategy for building, as Jim McClelland referred to earlier, the Iceland model of community togetherness. And then finally, don't let this be a fad. There are some things that we cannot afford to have them just be popular until we get tired of them. And this is one of those things. Infant mortality can't just be one of those things that we ride until we kind of grow weary because it's not getting better. It requires a sustained, diligent togetherness to see this through. Decades worth of work, generations worth of collective, integrated change to make it happen. So as we finish out our time this morning, my last quote on the last slide was, you can't whistle a symphony. And there's some method to that madness. When we talk about laborers of love, it takes all of our different types of labor together to really make a symphony that gives a big hug to our families and our kids for the state of Indiana. It is an honor to serve you in this role, not just because of the role itself, but because of the connections that we're able to make that are beyond what the walls of FSSA can hold, beyond what the walls of ISDH can hold, beyond what the walls of our hospitals and all of the different places where you all come from together. But together, let's whistle this symphony. Let's make it really loud and really beautiful. Thank you.